Good morning. Did you guys not have the link or everybody's just running late this morning? Morning. I'm just waiting for a couple more people to jump on and then I'm going to get started. We're going to do start with respiratory and then go into cardiac. So at 10 after, I'm going to start regardless of who's on. Morning. You should have practicum ones there. You're doing practicum today, right?
Yeah, we have two different ones.
Yes.
Oh, yeah, that's true.
This is for
Forget about it.
practicum.
Yeah. Don't forget that. It's okay. Yeah.
Good morning.
Babita. No,
Hi.
she will be with me in the class because I'm instructing her for her course.
Okay.
So you know she's in the class.
Thank you. Did your tab populate yet?
No, not yet.
I
But
sent them another
that's fine.
email.
Yeah, I already collected the email, so I could forward to you.
All right, I'm getting ready to jump on Zoom, so,
Oh, okay. So you know that Babita will be with me.
okay,
Saturday.
Thank you.
okay, no
Some
problem.
Saturdays, some evening, whatever her.
Okay. All right, we're getting there. We're starting to populate a little bit. I'm going to start at 10 after. For those of you that just came in, just trying to give everybody a chance to get on before I start. How's everybody doing this morning?
Good morning, Miss Loach. All right, how about you?
I'm good. I'm blessed, highly favored. I'm alive, standing on my feet.
Yep, that's good. That's what we need, right?
Yep. We're doing peds this morning. We're doing chapters 40 and 41 at your request. Respiratory and cardiac. We're going to start with respiratory. Oh, okay, they got 30 seconds to jump in. The first thing we're going to start talking about is just about the respiratory structures a little bit. Okay. About the different changes. Okay, so you know that the respiratory system is basically responsible for oxygen distribution and gas exchange. And as the child starts to grow, especially during those first like 12 years of their life, the anatomical aspects are different for them than they are for the adult. So that makes them more susceptible to certain things, different infections and respiratory problems during the childhood ages. Let me make sure this is recorded. All right, it is. All right, so the lungs, they're the main component of the respiratory system. You should already know that. They bring the air in, extract the oxygen, and get rid of that carbon dioxide. The right lung has 3 lobes, the left has 2. I always remember that because I'm right-handed. So I think about my right side of my body being stronger. So I have 3 on the right and 2 on the left. I do the same thing with the tricuspid and the mitral valve in the heart. All right. You know that there's a space in between the 2 lungs. That's called the mediastium. And the lungs are surrounded by the ribs, the vertebrae in the back, the sternum, and all that together helps to make up the chest. At birth, our chest is going to be round, all right? And then it starts to go towards a flattened shape across the front and the back as we grow. Certain respiratory diseases can alter the shape. You should already know that, like emphysema can give it that barrel shape. Or asthma, cystic fibrosis, those kind of things all can affect the shape. We have the upper respiratory tract, and that has the nose, the nasal passages, say it, Zoe, the nasal passages, the mouth, the oropharynx, the pharynx, and the larynx. All right, so the changes start right there at the nose for the infant. All right, the baby doesn't know, and it doesn't have that automasticity to tell it that if the nose is blocked, I need to open my mouth, okay? Even the girl babies don't learn that until way later in life. That was a joke. We gotta keep it fun. All right, so because of this changes in the system, our babies are gonna breathe through their nose. Okay, so they have a smaller nair, meaning that airway where the, in the nostril where the passageway is. They also have smaller nasal passages, and that makes them more susceptible to any type of airway occlusion. All right, they have to breathe through their nose, so their nasal passages have to be patent, okay, because they need to be able to breathe and feed at the same time. Again, they're not going to automatically open their mouth to breathe. Even if their nose is blocked, they can't automatically just open up the mouth and breathe, because neurologically, that component of the body is not going to develop until they're about 4 weeks old. All right, so respiratory disorders are the most common cause of illness and hospitalization in children, and it accounts for the majority of acute illnesses in children. Newborns are called obligatory nose breathers until about 4 weeks. Again, that's because that neurological component that tells the brain to open the mouth when the nasal passages are obstructed isn't working. All right, it's not developed yet. The upper and lower airway is going to be smaller in a child. The tongue is going to be larger in the baby's mouth, and that makes them more susceptible to that airway being obstructed.
Miss Sue,
Yes.
can you change the slides? Are you going off of your slides?
Not yet. I'm not there yet.
Okay, no problem. Thank you.
All right. So, but I could put the first one up because we are kind of getting there. There you go. So I was just covering the basics before we get to this point. So now we actually are going into this area where the infant is an obligate nose breather. So what does that mean? What did I just say that means?
They breathe through their nose. They don't know how.
That
They
does
don't
breathe.
know to open their mouth to breathe when their nose are obstructed.
Okay, so we
Because
have
of
to keep those
neurologic-
airways open, right? They're not
Mhm.
going to produce much mucus, okay? It's just a little bit of mucus that these babies are going to produce. And the mucus actually cleans, okay? But because they're only producing a little bit, they're more susceptible to infection. They will have the maxillary and the ethmoid sinuses present. Infections in the sinuses are a lot of times associated with the frontal sinuses and the sphenoid sinuses, which usually don't develop until about 6 or 8 years old. So these younger children are not as likely to get a sinus infection. The child's compliant airway is susceptible to dynamic collapse in the presence of airway obstruction, meaning that if the airway becomes obstructed, it's likely that their lungs could collapse. They have less alveoli. Remember, those are those grape-like structures in the lungs that actually do the air exchange. They're at greater risk for hypoxemia or a reduction in oxygen going out to the tissues and the body. They'll have a smaller airway. So because of that smaller airway, it can increase the resistance to airflow, and that can cause an increase in work or the breathing efforts. Yes. Good morning.
It's Lorna.
Yeah, I only have the students' ones. Do you need to print something? Yeah, you could just grab one of those student ones out there. All right, so after about 4 weeks of age, okay, air will start to enter the respiratory system through the mouth and the oral pharynx. And the remember that small oral cavity in conjunction with that larger tongue put the child at risk for airway occlusion. And when you think about airway, okay, why is that the first component that we address in a patient?
Need oxygen.
Okay, how
Yes.
fast will someone die if they don't have air?
Very fast.
Brain.
Very fast, right?
Oh,
30 to
yes.
40 seconds if they're not getting any air in. They could physically die. Now, the brain might not die for 4 to 5 minutes, you know, based on how well we do that CPR. But they're already not going to be breathing. It's going to stop if they can't get that oxygen in. The pharynx or the throat, that actually acts as a conduit for the respiratory and digestive tract. It's mainly made out of smooth muscle and mucous membranes. In there are going to be the tonsils and the adenoids. All right. And they can actually cause occlusion themselves if they became too inflamed. So after about the age of 12, they start to decrease in size. All right, the trach is about 4 millimeters wide. An adult trach is about 20 millimeters wide. So whenever that child has edema, mucus, or bronchospasm, it's going to greatly decrease the ability of air to flow through there. This is called a reduction. All right, and that reduction in the diameter of the airway is going to be from either edema or mucus that's present when they're ill. When that comes, that's going to cause resistance in that airway, and that's going to increase what we call the work of breathing. So I'm not sure how many of you use this term, but I didn't really know about, WOB until I started doing pediatric care. So when you hear someone talking about WOB, that's what they're talking about. What is the work of breathing for that infant? And that's the labor that's associated. All right. And then once they become a teenager or go towards adulthood, then the larynx becomes more of like a cylinder, more round and more open. Under 10, the cricoid cartilage is not developed yet, and that can cause narrowing of the laryngeal airway. So the larynx is going to be more funnel shaped. The larynx and the glottis are going to be up high in the neck, and that puts the child at a greater risk for aspiration, especially if anything foreign enters those lower airways. Then we have something called congenital malatia. This can happen in some infants where the laryngeal structure is weaker than it should be. And this can cause collapse on inspiration. It can also cause something called congenital laryngomalacia. So what happens is in these infants, when you're like feeding them, a lot of times they have a difficult time eating and breathing. And you'll physically see when they have this laryngomalacia, when they're eating the bottle, you can physically see like the airway collapsing, like around the trachea area. You can start to see retractions in the child sometimes if they feed too long, and you'll start to see an increase in the work of breathing because they're having problems manipulating the ability to breathe, especially if they're sick or they have some kind of cold, along with feeding. And a lot of times when they're eating, they'll actually end up going into respiratory distress. The trach is around the third thoracic vertebrae in children. In adults, it's going to be around the sixth. So when you suction kids, you have to assess for that respiratory, for that aspiration, and you have to know those differences. Also, we just talked about the laryngomalacia due to that funnel shape and the location of the larynx. And that also increases the chance of foreign material into the lower airways. You can maybe see that on box 40.1 in your book. Also, children have a higher metabolic rate than adults. So that's going to also affect their oxygen levels. They may consume more oxygen than the adult does. What else about that larynx can I tell you? It's rigid, okay? It has the epiglottis. Remember that overhang to the trachea, and the glottis, the opening to that trachea. All right, and that epiglottis and glottis, they keep those solid foods and fluids from entering the air passageway when we swallow. The glottis also has the vocal cords that produce the vocal sounds. And the child is going to have a long floppy epiglottis that is more prone to swelling. And again, that can also lead to obstruction. So if you look at this slide here, all right, it's showing you that we have this bifurcation of the trachea at the third thoracic vertebrae. All right, so again, that is important when we're suctioning or when we're intubating. We have narrower bronchi, so it's going to be less of a diameter, right? So if there's anything in there, that's going to, again, decrease that diameter or reduce it even more, putting that child at risk for obstruction. Remember, if they get an obstruction, that can cause those lungs and that airway to collapse. then they have less alveoli. So they're at a higher risk for hypoxemia. So what kind of things, well, let's just talk about airway resistance a little bit more before I move on, just to make sure you understand that. All right. Airway resistance, when we talk about that, that's the effort or the force that's required to move the airway into the lungs. It's already greater in children because the airway is more narrow than that of an adult. So their resistance is about 15 times greater than an adult. And whenever there's edema or swelling in that airway due to either something that's irritating it or some disease process, then it's going to become more narrow and even more resistance. This makes it harder for the child to breathe. And so when you look at the child and you see that this is going on, what are you going to see? You're going to see things like an increase in respiratory rate. You're going to see retractions, and you're going to see what we call nasal flaring. Because children have more of exposure to environmental smoke, you're also, and other environmental factors, you're also going to have an increased incident of respiratory illnesses like asthma, bronchitis, and pneumonia. So, you know, when we're looking at these kids, what are we looking for? That doesn't really differentiate much from an adult as far as anxiety and restlessness. We look for that in anyone who we think is hypoxic, okay? Because they're going to have a, when you can't breathe or you don't feel any air going in, it's going to change your level of consciousness. It's going to change the way you feel, okay? What other things are we looking at? The rate and the depth of the respirations, and that's going to vary, right, for kids. An infant's rate of respiration is what?
Around 30.
30 to 60. Okay. So, you know, you have to know that, because otherwise you're going to be calling 911 because your baby's got, oh my God, they're breathing at 45 breaths a minute. The color. So what kind of color changes are you looking for? Pallor, cyanosis. All right. How's their hydration status? Why does that matter?
Because they have more water than adults in the body.
Okay.
Their
because-
and the surface area, the skin surface area.
Okay.
That has to do.
So a couple of things. They have more fluid than an adult. All right. And because of that fluid status, they can easily have fluid and electrolyte changes. Now, those fluid and electrolyte changes can change what's going on in the body. All right. If our sodium's off, it can affect us neurologically, and it can affect our nerve transmission. If our potassium's off, it can affect muscles. It can affect cardiac. If our calcium's off, it can affect cardiac. It can affect muscles. Magnesium can affect our blood pressure, our circulation, and also our heart. Okay, so all these different electrolytes, if they're out of order, they can affect our ability to breathe, and they can affect our ability of our heart to maintain homeostasis in the body. It also can affect, as far as, you know, if my potassium were low, I could end up in an acidotic, in an alkalotic situation, or if it were high, I could end up in an acidotic situation. So, you know, acidosis or alkalosis is also going to what? As far as respiratory. How's that
It is
going
going
to
to
affect
affect the carbon dioxide is going to be retained if they have acidosis. They have they have a low, that means they have a low oxygen if they have a respiratory acidosis, and it's gonna.
Okay, they're going to be retaining too much carbon dioxide and not enough oxygen in the body, or vice versa. All right, they're retaining not enough, they're putting too much carbon dioxide out. Okay, so those are kind of things that we also would be looking at. And then other airway noises. So with children, how are they going to sound if they're having a respiratory issue? What kind of sounds would you be listening for?
Wheezing, stridor.
What stridors sound like?
It's like on when they exhale. Mm,
So stridor is an actual
high
blockage,
pitched.
okay? And sometimes you'll hear them describe it as a loud crowing sound. Sometimes you'll hear them describe it as like a barking seal type sound. Although a lot of times they'll associate that more with croup. So it's going to be a change in the way the sound coming out. Now with children, most of the time what
they're
you'll
doing
hear
a Zoom.
is a
They're
grunting
recording.
sound.
I said I would just listen for now. She's recording it, so we can go back and listen later.
Can you mute, please?
Yeah.
Can you mute, please? So, you know, they might do grunting. A lot of times you'll hear them grunting, and people will actually document this. They'll go, yeah, he's okay. He was just grunting. What do you mean he was just grunting? What'd you do about it? Did you investigate it? Because grunting usually is a sign that they can't breathe. They can't tell you they can't breathe. So there has to be some other sign or symptom that this is going on, right? So some of those adventitious breath sounds you're going to hear are wheezing. That's a high-pitched sound that you might hear on inspiration or expiration. It could occur with an obstruction in the lower tract or the bronchioles. It can occur in asthma or viral infections. And then these rels, like these crackling sounds. And those are usually indicative of either the alveoli having fluid in them, depending on what kind of crackling sound you hear. Sometimes you can hear the crackling when the patient has secretions and you're trying to move those secretions. Sorry, I have to change my note page. All right, so tachypnea, this is what we call increased work of breathing. And you might see that, you might see nasal flaring, retractions. Retractions look like the ribs are being sucked in, or it looks like the neck around the sternal area is being sucked in. So you're going to look like right around that substernal or clavicle area and in the intercostal areas of the ribs. That's where you're going to see the sucking coming in. With the nose, it's very obvious when they have the nasal flaring. You'll see the nose suck in and out. So you want to be able to define those adventitious breath sounds that you hear when you're auscultating. Make sure that you review the breath sounds that are heard over both the anterior and the posterior chest, the axillary area, including wheezing, rels, any other type of sounds like fremitus, tympany, or hyperrenaissance. So let's just talk about pulmonary circulation for a minute. All right, so in pulmonary circulation, the blood passes through the lungs, all right, to get oxygen, and then it goes out to the cells and the tissues of the body. It's basically a 4-step process. The oxygen depleted blood is going to enter the lungs from the pulmonary artery, okay, and that comes from the heart's right ventricle. The blood then goes through the main pulmonary arteries into those smaller vessels of the main bronchi, through those arterioles, into the capillary networks that surround that alveoli. And then the oxygen is going to go into the capillaries from the alveoli, and that oxygenated blood is going to go through those larger vessels and into the main pulmonary vein. And then from there, it goes into the left atrium. Once it comes into the left atrium, that oxygenated blood is going to go into the left ventricle, and go out through the aorta to the body. For the infant, okay, their ribs are made primarily of cartilage and they're super flexible. So they're not as effective in ventilating. So they use diaphragm or abdominal breathing, and the diaphragm will move up and down during inspiration. Negative pressure is created, and that allows the lungs to bring that air in. All right. They also use muscles to stabilize and to breathe. So they use the intercostal muscles of the chest. All right, until about the age of 6. After about 6, then they start to use the intercostal muscles for breathing. So before 6, they use the intercostal muscles to stabilize the chest. And then after 6, they actually start to use those intercostal muscles for breathing. Contraction and relaxation of the respiratory muscles will then start to move air in and out of the lungs, and the expiration becomes more passive. What are retractions? Okay, so when an infant or a child has difficulty breathing, they have these what we call retractions over those respiratory muscles. The depth and the location of those retractions depends on the severity of respiratory distress. So if we're mild distress, you might see just a few isolated intercostal retractions here or there. If they're in moderate distress, then that's when you're going to see the subcostal, the suprasternal, and the supraclavicular retractions. So remember, you're looking in between the rib cages, you're looking around the clavicle areas and around the neck. And if they're in severe distress, then you're going to see all these retractions. You'll see them at the rib cage, you'll see them around the neck area, and you'll probably see that nasal flaring, and you'll hear some grunting going on. When we talk about adventitious breath sounds, okay, we're talking about sounds that we normally would not expect to hear. In children or infants, remember, they have that younger, thinner skin, so the sounds might seem louder and worse than if you were listening to them in an adult. So for wheezing, what you would hear would be like a musical high-pitched sound in mid to late expiration. And you might not even need a stethoscope to hear it. Okay, when you hear that wheezing, you think edema and obstruction of the small airway, because that's what's going on. And so that's why we introduce what? Things to open up the airway and to get that breathing treatment into the lungs to try to open everything up, decrease the inflammation, and make sure that that airway is able to pull the air in. One thing you have to watch with a child that's wheezing, as long as they're wheezing and they're making sounds, they're moving air. Okay, if that wheezing suddenly stops and they're not moving air, Houston, we have a problem. Okay, you need to get someone in there to assist you. Okay, because the air is not going in, it's not moving. That child has minimal time there. All right, and remember, once the airway is blocked or once that obstruction occurs, then the lungs and everything may start to collapse with it, because that airway, remember what those muscles are doing there. Okay, we don't have that cartilage yet, so everything's weak. It's not fully developed there yet. Crackles. We can have crackles that are intermittent. They can be medium to high pitched popping sounds that we hear during inspiration. And because I said sometimes these can be indicative of secretions or fluid in the lungs, if they are attributed to secretions, a lot of times if you have the patient cough, it'll clear up or go away. So these are caused by fluid in the alveoli, the bronchioles, or the bronchi. Rhonchi is like a snoring, low-pitched sound. It's heard throughout respiration. And again, sometimes that can clear out with coughing. It's usually due to edema, some sort of obstruction in the large bronchi or the trach. Then stridor, I call it a high-pitched crowing sound. That's how I've always seen them describe it in the nursing text, but you may hear it described another way. But either way, it's an obstruction okay, at or above the vocal cords. So it's usually an upper airway obstruction. And then we have a pleural friction rub, which is like a grating or a rubbing high-pitched sound that we might hear during inspiration and expiration. And that's usually due to pleuritis or some sort of pleural inflammation. So what do you have to watch for when you're actually doing the assessment? One thing is what we call ventriloquist lungs. Okay, so sometimes you'll think you hear a sound in one spot, but it's actually in another place. All right, so an example of this is there might be mucus in the nose or the throat. Okay, and when you listen, it sounds like it's coming from the upper airway. Okay, but it's not really actually coming from that, it's actually coming from the lungs. But because of the mucus or whatever, it's changing the sound or the way the sound comes from. A lot of times you can listen in the axilla of an infant or a small child to hear those breath sounds. Okay, so just a little tip there. All right, the nurse is percussing the chest of a child with this suspected respiratory disorder. What sound might the nurse note that would indicate pneumonia?
Dull.
Dull?
Mm-hmm.
Is that what you said? Why dull?
Because of that fluid, it's gonna, when she's gonna percuss, it's gonna be the dull sound.
Okay, it's going to dull the sound because the alveoli or the areas are not air filled, but more fluid filled.
Fluid filled, yes.
Okay, good. The dull sound is usually something that we hear when we go over consolidated lung tissue, as with pneumonia, with decreased phremesis. That would be with a barrel chest or with somebody maybe with cystic fibrosis. Tympany, we might hear with the pneumothorax, right? Because that's air in the lung. That's what pneumo means. And then hyperrenaissance, this is going to be like a, most of the time we should have renaissance over the lung fills. All right, if we're going over areas of air. Hyperrenaissance might be seen with asthma. This is like a higher pitched or a more reverb kind of sound, if you guys understand what that means. When you're listening to the breath sounds, you can ask small children to breathe deeply by asking them to pretend that they're blowing bubbles, or that they're blowing out candles, or that they're blowing like the little flowers off of the little things that you pick outside, and you blow those little petals off of them. Those are how you know, because if you say, oh, breathe into this incentive spirometer for me, okay, or just blow or take deep breaths, they're going to look at you like you're crazy. They're like, what's she talking about? All right. So, you know, you can play games with them and teach them how to breathe or breathe deeply, and get what you need and make it a game and make it fun for them. You should listen with the bell of your stethoscope when you're listening for anything low sound, and with the diaphragm when you're listening for anything high sound. All right, so if the child has a suspected or diagnostic or a diagnosed respiratory problem, okay, they're gonna have to go have some either invasive or non-invasive diagnostic tests done, as well as monitoring. So pulse ox, okay, it might go down significantly in these children, all right? And so what are you gonna do? You're gonna be looking at this to determine if they're hypoxic or not. Other things that you might have to incorporate are spirometry and pulmonary function tests to assess any degree of disease. But that's not always the best choice for an acute issue. So, you're going to have to do a thorough assessment and look for issues or concerns. Now, as far as nursing, you're looking at things like insufficient airway clearance, altered breathing pattern, altered gas exchange, activity intolerance. These are the kind of things that you're looking at. Okay. And then you're going to base your care plan or your concept mapping on that. The diagnostic test, besides the pulse ox, you're looking at X-ray. Okay. This might show some sort of hyperinflation, or it might show atelectasis, which would be like a collapsed lung, or some sort of infiltration in the lungs. ABGs. These look at the gas exchange, okay? It also looks at the ventilation system to determine the blood's acid-base balance, and it helps us monitor respiratory therapy. The respiratory and metabolic system tend to work together, all right, to keep the acid-base balance in normal limits. So the ABG is done with a blood sample taken from the peripheral artery on an arterial cath, like an umbilical artery or an arterial line or a central cath. Okay, and pediatric values are going to be similar to those of adults as far as the ABGs. So if your client wore in respiratory acidosis, okay, you'd be looking for things like diaphoresis, headache, tachycardia, confusion, restlessness, apprehension, flushed face. Okay, and this is usually either some sort of central nervous system issue or from hypoventilation. Or if they were asphyxia in any way, like let's say the baby got a hold of a plastic bag or something and it got caught in his mouth or caught in his throat and it kept him from getting the air in. That could also cause a respiratory acidosis issue. Alkalosis, respiratory alkalosis. With this, you're going to see rapid, deep respirations. You're going to see things like paresthesia, numbness, tingling, lightheadedness, twitching. Also, you see anxiety and fear. And this can be from hyperventilation, respiratory stimulation from either drugs or a disease, even having a room temperature too high. It also can be caused by some sort of gram-negative bacteria. Metabolic acidosis. With this, you're going to see that rapid, deep breathing, the fruity breath, headache, fatigue, nausea, vomiting. These patients can go into a coma and they can have abdominal pain. So this can be from either losing too much bicarb through diarrhea, some kind of endocrine disorder like shock or DKA, all right, or the body is not putting enough acids out because the kidneys aren't appropriately working. And then metabolic alkalosis. With this, you're going to see slow, shallow breathing, hypertonic muscle use, restlessness, twitching, confusion. It can lead to seizures and a coma if it becomes severe. With these patients, they generally either lose hydrochloric acid from things like prolonged vomiting or gastric suctioning. Maybe they've lost potassium because they are either on steroids or they're using some sort of diuretic therapy, or maybe they've taken in some sort of alkalotic products and it's been too much and it's altered. So when you do the ABG, it would be a small sample from that arterial catheter. The child's shouldn't feel really any pain from this. The reason why you want to take it sometimes from the arterial area other than venous is because it's going to be more accurate. All right, so it might be a little more painful just for a couple of seconds just to do that draw, but overall it's not going to be a seriously painful procedure. Okay, so tell the child that you just want to borrow a little bit of their blood, all right, to do a test with it. Sometimes they can understand that. All right, and use the parents to help comfort the child and to help make the child understand that it's not going to be a terrible thing. It might hurt for a minute. You can also teach the child how to, count, squeeze your hands, praise them, do those kind of things, give them pretty Band-Aids and stickers. If the sample is performed through arterial puncture, then you have to monitor the arterial circulation. And we used an Allen's test to do that. Everybody familiar with that?
Yes. Okay.
Yes.
Chest X-ray is going to help us look at the internal structures, soft tissues, organs, and muscles. On the child, a chest X-ray, if you see white matter on there, it's indicative sometimes of something that's been aspirated, like a foreign body. So when you're looking at that chest X-ray, again, you're looking at hyperinflation, atelectasis, or possible infiltration. Also, sometimes on the X-ray, you might see things like dense tissue or dense bone. All right. You can look at infections. You can look at the size of the heart. You can look at the vessels and the cardiac chamber size, and you can look at the pulmonary blood flow. Let me see if I can find that something on this nasal pharyngeal washings. This is to help identify RSV or other viral illnesses, or we can use ELISA or immunofluorescent antibody testing also to look at these. And then we have rapid strep testing. That's usually done through a throat culture. When can we not do a throat culture? Come on, critical
Right after
thinking
they
here.
eat,
Huh?
right after you eat something, because whatever the particles are could get caught in the culture.
Okay, let me make it more clear. When would it be life-threatening to do a throat culture?
If they have something stuck in the airway, obstruction.
If they have epiglottis.
Or tonsillectomy or something.
Epiglottis, if they have epiglottis, okay, you wouldn't want to do a throat culture because it could trigger a laryngeal spasm. Just like, remember with epiglottis, what do they always teach you? Don't use a tongue blade. Okay, there would be no difference really between sticking that tongue blade in there and sticking a culture in there.
So you said it can trigger a laryngeal
Spasm
spasm, got it.
and close the airway. So think about, what is epiglottis? What does it look like? How are they going to present if they come in with this?
Gonna have trouble breathing.
Okay, but they're going to do specific things, like
Next,
children tend to tripod or lean forward when they can't breathe. They may have drooling because they're not able to swallow, and some of that fluid's coming out. They might have like a frog-like sound emitting from their throat, like a croaking-like type of sound. All right, and if they open up their mouth, what you're going to see in there is going to look like a big beefy red thumb.
mhm.
I mean, you see that, you're sticking nothing in that mouth, okay? So a pulmonary function test, that can help us look at the ventilatory function and assess lung function of children who have either acute or respiratory disorders. we can use something called serial testing, where we look at the different values over time. So let's just talk about a couple of the lung function tests. I don't know if this, let me see if this slide, just go down a couple slides and see if it goes into them on here. I just want to lay them out to you a little bit so you understand what they are when you hear people talking about them. Okay, so what the pulmonary function test does is it looks at the any restrictive or obstructive defects. So a restrictive defect is one where the person is not able to inhale the correct amount of air. All right, and sometimes that happens because they have some sort of deformity in the chest wall, or they have something that's a neuromuscular disease like Guillain-Barré syndrome or Lou Gehrig's disease, okay? Or they might have an acute respiratory tract infection. So if any of those things occur, they can have this restrictive problem. The obstructive problem is one in where it obstructs the lung flow or airflow in or out of the lungs. And it can occur in things like asthma, chronic bronchitis, emphysema, and cystic fibrosis. So when we talk about tidal volume is the amount of air that we exhale or inhale during normal breathing. All right, it can be affected if we have a restrictive problem. And if we did have a restrictive problem and our tidal volume was decreased, then we would need to have it furtherly investigated. Inspiratory reserve volume, this is the amount of air inhaled after normal inspiration, okay? And it doesn't indicate by itself any sort of respiratory dysfunction. Then we have expiratory reserve volume. This is the amount of air that can be exhaled after normal expiration. Vital capacity. This is the amount of air that can be exhaled after maximum inspiration. A normal or an increased vital capacity with a decreased flow rate can result in functional pulmonary tissue. So in not working right. So it's going to reduce the ability of that pulmonary tissue to work. A decrease in the vital capacity. We have to look at the diaphragm, the thoracic area, and the respiratory issues, because all these can be affected by that. And then inspiratory capacity, this is the amount of air that we exhale after normal expiration. We have forced vital capacity. This is the amount of air that can be exhaled after maximum inspiration. And then the last one is forced expiratory volume. And this is the amount of air that's exhaled in the first forced vital capacity. All right, so pulmonary function tests, for this to be effective, the child would have to cooperate and understand the instructions. Most children aren't able to do these until about 5, because you have to be able to manipulate the equipment. They have to be able to hold their breath and follow cues. All right, so you be teaching the child how to follow along and the parents on how to help you. For this sort of test, you have to withhold any bronchodilators and any intermittent positive breathing before the test. All right, so now that I explained that stuff to you, let's go back to the stuff we were talking about. So pulse ox symmetry, this is non-invasive, all right? We're looking at the O2 sats through that probe. A lot of times with kids, we'll put it on their toe, because a lot of times they're not gonna keep that probe on their finger, and if it is, it's not always accurate because they're moving around a lot. The sensor, again, earlobe wrapped around the foot is best. A reading at 85 to 95 is a good clinical range. However, we're really looking for something greater than 92 on these. All right. So a lot of times nurses will take a pulse ox on a baby and they don't look at the other aspects. Okay. So it's not just the pulse ox in itself. If the pulse ox is reading low, you want to make sure you have a good connection. Your pulse ox is working. Make sure it's thoroughly attached. Check your probes on it. Okay. And then what other things would you expect to see in this child if they were hypoxic?
Color change, skin
Yeah.
color.
Yeah. So you're looking at all that. Does it match what your pulse ox actually says? Okay. Okay. So for rapid strep and rapid influenzas, we use this, of course, to detect any strep throat or influenza. And then common lab and diagnostic tests for pneumonia you should be familiar with. Okay, so for pneumonia, we'd be looking at pulse ox, chest x-ray, sputum cultures to see what kind of pneumonia it is and what kind of bacteria. We would want to know that for treatment. And now with the antibiotic stewardships, what they'll do is they may go ahead and take the sputum, start the child on a treatment, and then depending on how the cultures come back, if it's positive for the bacteria or the agent that they suspected, and they started the child on the antibiotic that they want them to be on, then they'll go ahead and treat. And if it's for some reason showing that it might not work with that antibiotic, then they might even switch up the antibiotic. So that's why we can use the cultures now. And why would that be important? Why would you want to know if the culture is susceptible to the antibiotic?
So we can treat them with the right antibiotics.
And we
And,
don't want them to become where
Susceptible to
certain
other-
antibiotics don't work. So if we treat someone with an antibiotic for an infection that it's not going to work on, we can actually become like almost resistant to that antibiotic. And if we try to use it again for something else, it might not work. Okay, cystic fibrosis. White blood cells also for pneumonia, guys. If I didn't say it, I'm saying it now, white blood cells, okay? We're gonna look at that to see if it's elevated, okay? That would be for bacterial pneumonia. In viral pneumonia, you may not see that. All right, cystic fibrosis. We used to do what we call the KISS test on babies for this. Does anybody know what that is?
which one? I'm sorry,
did
can
you
you
say?
repeat it?
The KISS test?
Oh, the sweat test, like we check the forehead, like,
No, we used to do the KISS test. Does anybody know what that is?
No, I don't know about the case test. Yes.
So before they started doing all these other tests, okay, they would kiss the baby. And if the baby tasted unusually salty,
mhm.
because what is cystic fibrosis?
I have seen somebody
Oh.
doing it like on the child's forehead and just putting it on their lips. That's I have done and like seen it.
So it's really generally with this disorder, you have an issue with the chloride level, okay? And it causes the skin to be kind of salty. So cystic fibrosis itself is a chronic autosomal recessive inherited disorder. It's caused by the exocrine glands. It's characterized by chronic airway infection that often leads to bronchiectasis, bronchiolactasis, exocrine pancreatic insufficiency, intestinal dysfunction, abnormal sweat gland function, reproductive dysfunction. It's the most common fatal genetic disease in white children, and it's accompanied by complications. Life expectancy, this book that I'm giving you that from might be a little off from yours. I'm not sure what your book says, life expectancy. This one's only a couple years old, but it says 32 here.
Monsieur,
Yes,
I think our
does
book
it,
says 39.
our book says 39.
does it make the mucus like thicker too? The excretions?
Well, what happens is they're producing these excretions, and because of the way the body's functioning, the excretions can sometimes become thick or dry. But we're going to go into all that.
Okay.
So with cystic fibrosis, okay, it's, the exact issue remains unknown, but it's part of a gene in the body that helps regulate the chloride and the sodium transport. Okay, so when you have cystic fibrosis, that normal transport of sodium and chloride is going to be interrupted in some manner. So we have these abnormally thick secretions, okay, that affect the normal function of the organ system, like the bronchi. Okay, so we get chronic bronchial pneumonia and obstruction. In the small intestines, we get intestinal obstruction and failure of the neonate to pass meconium. Remember, all this is caused by these abnormally thick secretions. The pancreatic ducts can be blocked, and that causes malabsorption. The bioducts can be blocked, and that causes biliary cirrhosis and portal hypertension. The salivary and sweat glands will cause an increase in sodium and chloride excretion. And then the autonomic nervous system can cause some, it can cause hyperactivity in the autonomic nervous system. All right, so what are you going to look for in these patients? All right, at birth, they might have dyspnea, a dry, non-productive cough, wheezing, atelectasis, and generalized obstructive emphysema due to this mucus obstruction, okay? And as the disease gets worse, then they can develop that barrel-shaped chest, the cyanosis, the clubbing of the fingers and the toes. They can get chronic sinusitis, bronchitis, and bronchopneumonia. GI in the infant or the neonate, you're looking for meconium ileus, weight loss, malnourishment, obstruction of those pancreatic ducts, and the lack of pancreatic enzymes. So these babies are going to be faced with malabsorption, chronic diarrhea, and those large, what we call frothy, foul-smelling stools. Other things you might see is abdominal cramping, foul-smelling flatus, and cirrhosis caused by those portal hypertension issues with an enlarged spleen and esophageal varices. You guys know what those are? Those esophageal varices? Yes, no, maybe so. I can't talk to a nobody.
They are the ones they
Don't
can
engage, you're
rupture.
not going to learn.
They're like grape-like structures, like with the in the area, so they can rupture, risk for bleeding.
So they're blood vessels that have ruptured. Esophageal varices are blood vessels in the portal system, okay, where the liver is, and they rupture and they bleed. The reproductive system for these patients. So decreased fertility, all right, due to the viscosity of the cervical mucus that blocks the entry of the sperm. Sterility in males, okay, because the abnormal secretions prevent the sperm from falling. The heart, how does this affect the heart? So cystic fibrosis, what are we going to see with the heart? Right-sided enlargement, or something called cor pulmonale, and heart failure from obstruction of the pulmonary blood flow. Hyponatremia, causing circulatory collapse if we're not able to replace that sodium. Diagnostically, we're going to see an elevation in sodium and chloride levels on a sweat test. The stools will show us what we call steatorrhea, or fat in those stools. Chest x-rays, generalized obstructive emphysema. So one of the major complications is a pneumothorax. Other complications, bronchiectasis, intestinal obstruction, rectal prolapse, cor pulmonale, which is that right-sided heart failure, diabetes, mellitus, and nasal polyps. How do we treat it? All right, so improving the airway function, removing the mucus, and giving antimicrobial agents when we need it. We have to keep the infection away from these patients. So we use things like flutter mucus clearance devices, or hand PT, all right, increasing fluids, trying to keep those secretions moving. We might use bronchodilators, okay, to help open up the bronchi. Recombinant human therapy, all right, to decrease the viscosity of the mucus, and then physical exercise to stimulate the secretions, all right. Oxygen if they have an acute episode and it's needed, but it's used cautiously because a lot of these patients will retain the carbon dioxide. So we're doing this sweat chloride test. We'll consider it suspicious if the chloride or the that is collected is above 50 MEQs, and diagnostically if the level is above 60. Pulse ox, again, chest x-rays, because these children are at risk for pneumonia. They're at risk for lung collapse, okay, bronchial wall thickening. We might use some of those pulmonary function tests. Remember, we talked about the decrease in the forced vital capacity. What is that forced vital capacity? And the forced expiratory volume. So with that, you're going to see decreases, and then in the residual volume, you'll see an increase. Common medical treatments: oxygen, high humidity, suctioning, chest PT, postural drainage. When do we usually do that? When do we do that postural drainage? When's the best time to do it?
Before they eat.
All right, so we want to do this usually in the morning on an empty stomach before meals. All right. Saline gargles, that can help with throat pain. We might use saline lavage. This can be introduced into the airway, followed by suctioning. There's a little bit of back and forth about this, okay? Because a lot of people still believe in introducing the saline products. I myself don't. I feel like when we put the saline in, it causes the secretions to drop down in the bottom of the lungs, and we see a lot more pneumonia. Other people will say that the saline actually brings the mucus out. So it's a lot of controversy around it. There's no evidence really to support either way, enough for me to lean into that. But that's the thought process as far as the lavage on it. Mucolytics, how are these going to help? What do mucolytics do?
They're gonna help the mucus come out, and it's gonna thin the mucus secretions.
Okay, it's going to help that mucus secretion break down so that we can get it out. And then chest tubes. We might need chest tubes. We might need to do a bronchoscopy. What can we do with the bronchoscopy?
What you mean?
How can we help the patient with the bronchoscopy? Talk to me, nurses. I only hear one person talking. Who's listening? How can we help this patient with the bronchoscopy?
I don't know.
They can pull out the mucus maybe.
Okay, good. It can remove those foreign bodies or cleans the bronchioles. And then afterwards, you got to monitor for airway swelling, sore throat. Chest tubes, how could those help?
They also remove the secretions.
Yeah,
Prevent the lungs
drainage.
from
They remove
collapsing. Secretion from it.
To remove drainage.
yeah.
Okay, really, we use chest tubes most of the time to reinflate the lungs. And that's why we have to take that drainage out or whatever's in there out, because we need to reinflate the lungs. So if you notice when they're talking to you about chest tubes, that's what they're talking to you about. How should the water level be? How should the suctioning be? What would it look like if the lung were reinflated, right? That's all stuff they test you on when they ask you about chest tubes. If the tube becomes dislodged, we place it open end into a container of sterile water. Now, your author says it can be clamped, okay? I probably would check with my policy on that, because my impression is we don't clamp chest tubes anymore, but you could put it into that open container of sterile water. That would prevent the patient from developing another pneumothorax or going into a life-threatening condition. Because if the tube pops out, you have to do something. You can't just leave it out, or else they are going to develop a life-threatening condition. The nurse is caring for a child with cystic fibrosis. Which of the following treatments would be used to promote mucus clearance through percussion or vibration?
D.
Physiotherapy.
SPT.
Chest PT. So, you know, a lot of times when you go into the home, you don't always have what you need there to do the chest PT. What I'll do is I'll take a tongue depressor and excuse me. Help, nurse. I'm joking.
Are you okay?
Annie is not okay. All right. So what I'll do is I'll take a tongue depressor and I take just the mask part from a CPR mask or from a valve mask, and I tape it on there. And you can use it as a, you know, because you got to either use your hand in a cup form, or you got to have one of these diagnostic things that you can buy. It's like a little cup, and you tap it on the back or on the chest, and it causes this vibration to move the secretions. So a lot of times you won't always have that stuff in the home. So you might have to be a little creative in making some sort of suction cup that you can actually do the PT on the chest or on the back with to help the patient. And then also you want to position the patient. So positioning, I would like lay them across my chest, you know, if the child's small enough, and let their head be down a little bit. So as you're doing the PT, that gravity can help move those secretions out as well. So what kind of risk factors, all right, are we looking at that we have to think about for these children? What precipitates them to needing something? So premature birth for sure, right? Why?
Because the lungs are not properly developed by the time they're born.
Okay, their lungs may not properly be developed. So is it better for the child to be born in the 7th month or the 8th month?
8 months.
8 months.
Yeah, we always heard 8 months. That's what they always told us because they're more 7 months. I'm sorry, not 8. 7 months, believe it or not, is what they always taught us. 7th month that they have a better chance of development. So what are some things that we might give them if the lungs were premature?
Perfect.
Surfactant.
Steroids.
The steroids.
Okay, steroids or surfactant, okay, to try to help those lungs start to work. Hey, so I don't know what time my people are supposed to be getting out of here, but I know what time I need to get out of here.
Okay, I think they're getting out here.
Okay. I'm trying to find this page in your book for the risk factors, just because I want to make sure I give them to you correctly. All right, other chronic illnesses that might affect, I might not even need it because there's enough on this slide probably. Diabetes, okay, how would that affect?
The baby will be, weight will be high, and they won't be able to breathe properly because the insulin, they're producing the insulin, but they don't need it. So the blood glucose will be low. And that will affect their whole body system.
So if I were thinking about diabetes, really, as far as respiratory, I'd be thinking more along the potential factors of developing acidosis or something along that line because of the blood sugars being out of control. Sickle cell, how would that affect my respiratory? I need some other people to talk, please.
The oxygen won't be able
Because the
to.
cells are sickled.
Okay, so what's that mean?
They don't have like
Decreased oxygenation for the red blood cells
Why?
because the red blood cells are not properly formed.
Okay, but so how does that affect oxygenation?
I believe that the occlusion of the red blood cells on the joint prevent the oxygen to go through the lungs.
Okay, good. The occlusion of those cells stops that oxygenation from flowing through. Also, the cells die a lot quicker. They don't live long. So the body's trying to keep up to constantly reproduce. And sometimes in certain respiratory disorders like COPD, what actually happens in regards to those red blood cells? What secondary condition can we get from this?
Can we get from sickle cell?
From a respiratory disorder in general, when we're chronically hypoxic, what kind of secondary condition could it cause us to develop?
SIAD, syndrome of inappropriate antidiuretic hormones.
No.
is it
If I'm chronically hypoxic, what kind of
COPD?
condition might I develop? Because my body's always trying to be in homeostasis.
COPD.
So it's actually polycythemia, too many red blood cells, because my body recognizes that I'm not getting the oxygenation. It just doesn't really know why. So what it's going to do is try to keep replacing those red blood cells. And that's going to cause me more problems now, because if I have too many red blood cells, okay, that can cause me problems also. It can make my blood thicker. It can make me more predisposed to blood clots and other issues. Cystic fibrosis, we just talked about. Any kind of heart disease, okay, if the heart's not pumping well, if it's not getting oxygenation out, it's going to affect our ability to breathe, okay, because blood will start to back up. It's not getting out to the tissues, so the body is not getting oxygenated the way it should be. And then any sort of chronic lung disease. Developmental disorders like cerebral palsy, exposure to cigarette smoke, immunodeficiency, crowded living conditions, because this puts us at risk for things like TB, And then daycare attendants, of course, when children go to daycare, they pick up all sorts of germs and respiratory infections because they are predisposed to other people. All right, so then they'll also have some risk factors for HIV. What would those risk factors be?
I'm sorry, what did you say?
Risk factors for HIV. What kind of risk factors? Think
Unprotected.
about children in general. How would
Maternal.
they be exposed to HIV? Through their parents, right?
Yes.
Through their family.
Mm-hmm.
So, I mean, there's a lot of ways, right? Mom could be infected. Someone in the family could be HIV positive and be molesting them. How would that person get HIV or TB? So drug use, incarceration, TB, either exposure, living in crowded conditions, living in homeless conditions, immigration, traveling to other countries, drug use.
Compromised immune system.
So all these things can put them at risk. All right, so to reduce tuberculosis, okay, you as the nurse, we have to look at all infants, children, adolescents for risk factors. We have to do that TB screening as recommended. We have to refer any TB infections to the local health department and educate the family about risk factors and signs and symptoms. All right, pneumothorax. So what is this? Air in the lung or air in a spot where it's not supposed to be, okay? It's usually caused by either chest trauma or surgery, intubation, mechanical ventilation, history of chronic lung disease, such as cystic fibrosis. So how's your patient going to present if they have a pneumothorax?
When you try to listen to the lung sounds, one side is going to be diminished and the other side is going to be active.
Okay, so you may not hear any lung sounds on one side.
Right.
What else?
Retractions and nasal flaring.
Pain.
Hyperventilation.
Okay, they might also sound anxious. All right, because they're having difficulty or shortness of breath with the breathing.
Doesn't even feel it.
So with the child with a pneumothorax, they might have either sudden or quick onset. Again, you're looking at things like chest trauma, surgery, intubation, any kind of mechanical ventilation, any kind of history of lung disease like cystic fibrosis. You're looking for chest pain, increased respirations or tachypnea, retractions, nasal flaring, grunting, pallor or cyanosis. you're going to assess or auscultate for tachycardia, and you're going to look for absent or diminished breath sounds on the affected side. And then on the X-ray, you would actually see air on the X-ray. Other acute infectious disorders that you might see in these children are common colds, sinusitis, the flu, pharyngitis, tonsillitis, laryngitis, croup. This is where they have that seal-like cough. A lot of times children will wake up with this. It sounds really scary, okay? And parents might want to rush the kid to the ER. The best thing really they can do for this is to take them into a bathroom, all right, and steam it up. Steam it up so it's hopefully going to open up those passages, okay, and make it easier for that child to breathe. A lot of times they just want to rush them to the ER, but really when they get down there, there's not a whole lot that the ER is going to do for them more than what you could actually do for them in the home. Just looking on here to see if there's anything on here I want to go over with you guys that you might see on a test. They love to test on the croup. So usually that's what they're talking about, though, is just bringing the baby into cool air. I'm just going to go over this a little bit with you. I'll go over a couple of these. All right. So for the croup, also called acute laryngo tracheobronchitis, it affects the upper airway. Okay, it's usually in kids under 5. It causes severe inflammation and obstruction in that area. It usually happens around the late time in the fall or early spring, you know, around those allergy seasons. So it usually starts with some sort of viral infection, RSV, H influenza, or mycoplasma pneumonia. It happens to boys more often than girls. It's usually that upper respiratory infection first, and then they get the laryngitis, and that goes into the trach or the bronchial area, causing inflammation in that mucus lining and narrowing of the airway. And then we see the obstruction and the compromised ventilation. So what we hear is that barking, that seal-like barking. Okay, and that's because of the larynx being so flexible in the child, and it can cause complete airway obstruction. So it's characterized by gradual onset of low-grade fever. It usually is going to be worse at night. They'll have a cough. They might have retractions, restlessness, anxiety, tachycardia, and tachypnea. And then it can, if left untreated, go into respiratory exhaustion, hypoxemia, carbon dioxide accumulation, and respiratory acidosis. So what are you going to look for? History of respiratory infection, inspiratory stridor, and retractions, either sub or suprasternal, barking, cough, and hoarseness, pallor, and cyanosis, restlessness, irritability, low-grade fever, crackles, rhonchi, expiratory wheezing, localized areas of diminished or absent breath sounds, retractions, wheezing, and cyanosis. And diagnostically, they might do like a neck X-ray, looking at the epiglottis and the neck. If the obstruction is severe, then they might look at the ABGs. Okay, so most of the time, again, for the croup, they're going to use either vaporizers, oral fluids, antipyretics. The major thing is to maintain that open airway and allow for adequate respiratory exchange. So again, we're looking at high humidity with cool mist. So that's why we talk about the steamy bathroom. All right, in the hospital, they might take him camping and put him in the tent. All right. Signs that you would want to teach the parent. So you want to teach the parent how to recognize if their child's in respiratory distress. So they'd be looking for things like dusky or cyanotic skin, severe stridor, retractions, and any kind of agitation, restlessness, or mental dullness. All right, what else? Pneumonia and bronchitis. All right, so with pneumonia, we have acute inflammation or infection of the respiratory bronchioles, the alveoli ducts, the alveoli itself. Okay, and it can be from a virus, a bacteria, or aspiration. Viral is the most common type, with RSV being the most common organism. And it can happen bacterial pneumonia from strep or staph. Usually if they have bacterial pneumonia, they may look a little more sick, or they may be a little more sick than with the viral. So it usually starts as an upper respiratory infection. And then as the bacterial infection starts to invade the body through the bloodstream, it goes into the lungs. Okay, and then it starts to invade the upper respiratory system. So the virus or the bacteria moves into the cells, and they actually kill the cells. They fill the alveolar spaces, okay, and that causes that consolidation that we're talking about in the lungs. The most common bacteria will sometimes involve both the lobes and consolidation. So when that happens, we might see inflammation of the interstitial tissues. Causative agents or symptoms can include elevated temperature, rhonchi, crackles, wheezes, shortness of breath, increased respiratory rates, restlessness, and decreased sounds if that consolidation does occur. So how's the baby going to present? All right, they might have vomiting, they might have seizures, they might not want to eat, diminished breath sounds, circumoral cyanosis. These things you're going to look for. Older children might have a headache, abdominal or chest pain, high fever. They might be drowsy, tachycardic, grunting. So diagnostically for pneumonia, the chest x-ray, the sputum specimen, the blood cultures, the white blood cell count, and the ABGs. And then if there is material in the lungs that needs to be moved or something needs to be cleaned out, they might do the bronchoscopy, and they might actually culture that as well. And then pulse oximetry. Bronchiolitis. This comes on with that clear runny nose. The patient might have pharyngitis, a low-grade fever. It generally is going to develop about 1 to 3 days into the illness, and then they may have wheezing and poor feeding. So with children, you're always looking at the feeding aspect because, you know, with kids, there's not much they can do. They can eat, they can play. But when they're not eating, something's wrong. Other issues: allergic rhinitis, asthma, chronic lung disease, bronchopulmonary dysplasia, and cystic fibrosis. Let's just go through a couple of these. I'll go through the asthma and the bronchopulmonary dysplasia. We already went through the cystic fibrosis. So with the asthma, all right, this is a chronic inflammatory airway disorder. It causes hyper-responsiveness of the airway in response to stimuli that gets in that airway. So what we'll have are bronchospasms, increased mucus secretion, and edema of the mucosal airway. It's characterized by things like recurrent coughing, wheezing, shortness of breath, a reduction in the expiratory flow, exercise intolerance, and respiratory distress. So what happens is we get this inflammation of the lungs, okay, and the protective mechanisms of the lungs, like the mucus, all right, and that causes swelling and airway muscle contractions. The lungs start to overreact in response to whatever is triggering them. And that causes the patient to become anxious, okay? The body starts to release histamine and other chemical mediators that result in the patient having this bronchospasm. And after they start to have these bronchospasms, then they become even more anxious. So it's a back and forth process between that physiological response that's going on in the body and the anxiety it's causing in the patient due to the stress of not being able to breathe. Triggers: exercise, viral or bacterial agents, allergens, pollutants, changes in weather, food additives. And sometimes there are other things that can trigger it, okay? Patient can have what we call extrinsic or atopic asthma, and that starts in childhood where they're allergic to specific allergens, all right? Or they may have a family history. Things that would be considered extrinsic would be like pollen, animal, dander, or dust. Intrinsic, okay, would be some sort of internal factor that the body is acting to, like emotional stress, fatigue, endocrine changes, a change in temperature or humidity, anxiety, coughing, those kind of things could also trigger, and they would be called intrinsic. There's no genetic, there's two genetic influences from asthma. One can be an abnormal gene, and the other one can be just the tendency to develop a hyper-responsive airway. So how it happens, okay? Asthma follows a predictable course of bronchospasm. The tracheal and the bronchial linings overreact to that stimulant, causing the smooth muscle spasm that constricts the airway. The mucosal edema and the thick secretions also block the airways. IgE, or immunoglobulin antibodies, are attached to histamine containing mast cells and receptors, and they initiate the asthma response from within the body. Then when it's exposed again, okay, the mast cells start to degranulate and release these mediators, and they actually cause the bronchoconstriction and the edema. As the expiratory airflow decreases, it traps the gas in the airways, and that causes alveolar hyperinflation. And then, of course, that lung collapse or that atelectasis may occur in some parts of the lungs, and you may see an increase in airway resistance. That starts that labored breathing. Remember, we talked about the airway resistance, about it being the ability of that air to get into the lungs. Now, what happens over time is we have what we call modeling of the airways. Okay, so the airways have been altered so much that they actually start to take the shape of the alteration that has occurred within them. And so we see repeated episodes now of bronchospasms, swelling of the airways, mucus plugging, and that is going to continue to damage those irritated airways and scar the lining. So you would see a sudden onset of breathing difficulty. Then you might hear that wheezing or that coughing. You'll start to see the rapid and the labored respirations, and the patient might look tired. Okay, nasal flaring, intercostal retractions, the productive cough, and the wheezing. They'll start to use those accessory muscles. There'll be a decrease in the air movement. Over time, they can develop that barrel chest, and they'll also have use of those accessory muscles. So to diagnose asthma, they might look at the PaO2 and the partial pressure of carbon dioxide, pulmonary function tests, IgE levels, sputum analysis, chest x-rays, ABGs, and they might do skin testing to determine if the patient's allergic to specific things. They also have something called the Bronchio Challenge, and that could help with skin testing and do all of these things. EKGs would show if there's cardiac changes after the fact, like cor pulmonale, that right-sided heart failure, or symptoms of that, you know, EKG changes on there that looks similar to that. So we're going to treat it. All right. We use prevention. We use anti-inflammatory agents. So those would be like your steroids. We use bronchodilators to relax the smooth muscle and open it up. Leukotriene modifiers like Singular or Montelukast. They can help for long-term treatment to improve pulmonary function. They also help enhance the work of the steroids. And so sometimes if we use both the steroid and the leukotriene modifier, we can decrease the dose a little bit. They might use allergy shots or oxygen. And of course, you know, the breathing treatments with the albuterol and all that good stuff. Okay, bronchopulmonary dysplasia. Let's see what I have on that. I might not have much on that, but we're going to try. I'm compromised this morning. My computer crashed right before you guys came on, so I got to use a different computer, and that's slowing me down a little bit. I apologize for that. But hopefully what I'm telling you guys is helping. Okay. Yes, no, maybe so.
Yes.
Okay, so chronic lung disease, formerly known as bronchopulmonary dysplasia, is going to be seen in those babies, usually that have had RDS, respiratory distress syndrome. and also when they're using that long-term use of oxygen, usually greater than 28 days. All right, it's often seen in premature infants because they are getting those respiratory and oxygen treatments. And factors that are related to it are the immaturity of those pulmonary lungs, the any acute lung injuries, any inflammatory issues. Those things can all affect the lung, the structure, the growth. Any ciliary loss or airway lining issues that would make the patient more susceptible. In these patients, the alveoli is going to be reduced by 1/3 to 1/2. These babies might have a low birth rate. Typically, they're going to be white and male, and they're at increased risk for development of the chronic lung disease. Complications include pulmonary artery hypertension, poor pulmonol, congestive heart failure, and bacterial or viral pneumonia. And then usually for this, they're using anti-inflammatory medications that can be inhaled for long-term and short-acting bronchodilators for acute episodes. Again, a lot of these patients have been oxygen dependent for a super long time. All right, so we talked a little bit about asthma. The main things that you want to remember, it's a chronic inflammatory airway disorder. The airway is going to have hyper-responsiveness, meaning it's too active. This causes production of edema, and also that edema can affect the mucus. Mucus is being produced excessively. That results in airway obstructions that can be either partial or completely reversed. Sometimes we're going to use things like the bronchoscopy if we need to remove some of those secretions. It's going to be triggered by things like allergies, exercise, and how are we going to see it present in the body? So tachypnea, increased breathing, increased work of breathing, cough, wheezing. They use a tiered system. So what you'll see when you go into patients' homes, they usually have these yellow zones, green zones, all that stuff, and they're all different asthma management plans. So it depending on what their how they're doing, what their status is, okay, they might be on the regular routine asthma management, or they might be on the yellow zone where you're doing more treatments more frequently, and you may be incorporating some other things in your normal everyday medicines. But for rescue breathing, we're using those short-acting bronchodilators. And then for maintenance, the leukotriene modifiers, the inhaled bronchocorticosteroids, and the long-acting bronchodilators. For cystic fibrosis, okay, we talked about it being an autosomal recessive disorder. Okay, that's CFTR, that's that gene I was talking about that has a possible mutilation in it, and that comes from the exocrine glands. And so that they believe that that gene is what causes that excessive mucus in the lining, in the airways. And remember that excessive mucus affects a lot of spots in the body. It affects GI, it affects cardiac, it affects reproductive. It also is going to affect the pancreas, right? We're going to see a decrease in those pancreatic enzymes. We're going to see fat in the stool, and that can cause things like malabsorption, hypersecretion of any sort of gastric acids. For treatment for the cystic fibrosis, okay, main ones, chest PT multiple times a day, inhaled Dornase alpha, that's that pulmonary enzyme, antibiotics, pancreatic enzymes for supplements to help us break down. ADEK, those are your fat vitamins, okay? A DEC. So you're going to need fat vitamins. And then well-balanced, high-calorie, high-protein diet. They like to test on that stuff, by the way. I would know this slide. Other treatments they might use, okay, high frequency oscillators, nitric oxide inhalation, pure fluorocarbon liquid. That's going to act like a surfactant to help with the gas exchange. And then the extracorporeal membrane oxygenation. All right, epiglottis. Let's talk about that for a minute. Then we're going to move on to cardiac, hopefully, because we're almost done with the slide. All right. I want to try to get both in for you guys today. All right, so this is this acute inflammation of the epiglottis. It happens mostly in kids between 2 and 5. It will obstruct the airway and it is life-threatening. Usually comes from an infection with H. influenza type B, but other things like pneumococci or strep A can affect it. It's usually preceded by an upper respiratory infection or a sore throat several days prior. The child will go to bed with no symptoms and then suddenly wake up with a sore throat, difficulty swallowing. Again, it can lead to increased airway obstruction that causes hypoxia, hypercapnia, acidosis, decreased muscle tone, and then altered level of consciousness and obstruction, then death. So health history and physical symptoms, all right, sudden onset of the symptoms, preceded by a upper respiratory infection, sore throat, pain on swallowing, any kind of refusal to eat or drink due to difficulty swallowing. The child might say, there's a frog in my throat, or they might sound like there's a frog in their throat with this muffled, thick voice. They may have wheezing, inspiratory stridor, and snoring with that frog-like croaking sound on inspiration. And they may position themselves sitting upright or leaning forward with the chin thrust out, the mouth open, and the tongue protruding, what we call a tripoding position. All right, and then they're drooling because of either the difficulty or pain with the swallowing. High fever, irritability, anxious, apprehensive. They may look toxic. They're going to have those retractions, supra and substernal, tachycardia and thready pulse, and hypoxia. So they're going to feel, they're going to look listless. They're going to be cyanotic. They might have some bradycardia. And then their respiratory rate can decrease, and they may have a decrease in the amount of air being moved. If you do see the inside of the throat, again, it's going to look like a large cherry red thumb, or you're going to see this large amount of redness and swelling. All right, so the throat inspection would only be done by a specialist or a properly trained person. You need to have emergency equipment at the bedside for intubation or a tracheostomy. The X-ray of the neck will show that the epiglottis is enlarged. The white blood cells also could help with the diagnosis. They may be elevated, and there may be some sort of bacteria determined on them. It does rapidly progress, okay, and the airway can shut, and if it's not treated in a proper manner, then the child can die. So first line is antibiotics, okay, IV, and most of them are going to also get steroids. You have to get that airway clearance going on. All right, make sure that's happening for the child. And then you're looking for any signs of respiratory distress or infection. You're monitoring that respiratory status closely. If they do have to be intubated, then you're going to make sure you suction, provide oxygen, and you're constantly monitoring for a respiratory distress. You're going to make sure that they have adequate hydration because they're going to be getting these IV fluids. You're going to have to monitor their eye and nose. You need to help maintain a calm environment so that they can relax and calm down. They're going to be scared, and the parents are going to be scared. Other medications that you might have to give are antibiotics and maybe possibly some sort of sedation. Post-tonsillectomy. So what kind of things you guys know about that? You believe in taking the tonsils out?
No,
Why?
because they're like our limbs, so we need them to fight infections. But if they're really, really inflamed and they have bad infection, then the doctors take them. But I don't believe it, taking them out.
Everybody else?
Well, I believe that if it is infected, it can cause more harm than good. So it helped with infection, as someone said. But if it's going to cause more problem than good, it's going to be swollen. The case is not able to swallow because it's so swollen. I don't see the point of keeping it there.
I think it also will be affecting the heart if it's, I mean, if it's swollen and has other kind of infection.
Okay. So, you know, inflammation of the tonsils can happen with pharyngitis. It can be bacterial or viral. All right. Bacterial requires only symptomatic treatment. And if it's bacteria, they'll probably get some sort of antibiotics. Okay. Occasionally they do want surgical intervention. I'm not a fan of removing the tonsils because eventually the infections with the tonsils will stop. All right. But if you remove them, then you're actually removing, to me, an important part of the body that could actually help this person fight different other types of infections. And I'm a person who had probably strep throat. If I've had it, I don't know, 300 times in my life, probably. So they wanted to take my tonsils out. My mom wouldn't let them. And I still have my tonsils, but I no longer get strep throat or rarely ever get any problems with the tonsils. But they would get swollen to the point at times where they would almost close my entire throat off. And then I probably wish that they would take them out.
Mine was like that and it's taken out.
So usually when they become hypertrophied like that, sometimes they will want to take them out. Okay. And the same with the adenoids. So when you're looking at these patients, you want to see how are they after the surgery. Okay. So again, after the surgery, you're looking at ways to promote airway clearance. Okay. So until the child's fully awake, you should keep them in a sideline position to help with the drainage. All right, they're going to have some secretions. And then once they're awake, they might want to sit up or they might want the head of the bed elevated. Really, we don't suction unless it's absolutely necessary. Why?
To avoid additional trauma.
Oxygen.
Okay, to avoid additional trauma. And you don't want to bust the suture lines. Okay. And you might see things on the teeth and in the nares after the surgery. All right. You might see some blood there. The parents might see some blood there. All right. So make sure they're aware. What other things are you going to look at for this child? All right. Fluid volume. Post-op, you're monitoring for hemorrhage. What would be an indication of the hemorrhage?
Constant swallowing.
Swallowing.
Okay. frequent swallowing. That can happen up to as long as 8 days after surgery. So you're actually looking in the throat, all right? You might see some mucus blood tinge stuff. If it's fresh blood or if it's bright red blood or continuous swallowing, then you might look for other signs like tachycardia, pallor, restlessness, throat clearing. These things can also be signs that your patient's bleeding. You want to try to discourage the child from coughing, clearing the throat, blowing the nose, or using straws, okay, until the area is healed. Other things you would probably tell them to avoid would be things like citrus juice or any brown or red fluids, because if they throw up, then you might think that it's blood. And then you could encourage them to do things like popsicles, ice pops, things like that. In the first 24 hours, the throat will probably be pretty sore. They may need narcotics, they might not. And you're gonna wanna start, pushing those fluids. And then teach the patient and the parent how to control pain once they're discharged home. The main thing you wanna really do is have them continue to drink those fluids. All right, infectious respiratory disorders, epistaxis. What's that?
Nosebleed.
Nosebleed. So how are you going to handle that?
You have to put pressure on the tip of, on the bone, the tip of the nose.
And how would
Stop
you
the bleeding.
position the patient?
Sit up
Lean
straight.
forward.
Forward.
All right, we
Lean
want them to
forward.
lean forward a little bit.
Yeah.
What other things could you do besides pinching the nose?
Ice.
Give them an ice.
Ice pack on the
Where are you going to put
forehead.
the ice?
I usually put ice on the nose
Or
Nose
the
and
back of the
forehead.
neck?
or the back of the neck.
Yes.
So put the ice towards the back of the neck.
You could put it on the back of the neck, or you can put it on the nose itself.
Oh, I never
Okay.
heard of
Usually the
Yeah.
nose.
Most of the time, nosebleeds aren't really caused by anything specific. A lot of times you will see them in younger child that has asthma and stuff because, or allergies, because the nose gets dry.
Mhm.
Bleeding should stop within 10 to 15 minutes. Foreign body aspiration. Who does this happen to?
Little kids.
Babies, toddlers.
Infants, toddlers.
Okay. They like to put stuff in their mouth and we like to leave it around for them.
In your nose too.
Yeah, they'll put it in their nose too.
Yeah.
Okay. And, things that they like to swallow are things like buttons, coins, those kind of things. Okay. If it does get in there and it goes down to the bronchus, then they may have to do surgery through a bronchoscopy to remove it. Sometimes they'll use post-op antibiotics. And you have to be careful because you have to make sure whatever they swallow isn't anything sharp that could actually, slice or cut something as it's going through the digestive tract. Acute respiratory distress syndrome. What is that?
I guess just like how it sounds.
Just like how it sounds?
Mm-hmm.
How does it sound?
It sounds like something you don't even know the cause, like it happens acutely. All of a sudden,
So it happens acutely.
yeah, your
It
breath.
could happen from smoke.
We could have what?
It's probably
It could happen from smoke, like when they inhale smoke, or if they've been in the pool or they were drowning, something like that, or viral infection.
Okay, and how many of you know about this new thing now that they're talking about where your child can go to the pool potentially drown, come out of the pool, come home, go to sleep, and then drown in their sleep.
Is it like dry drowning?
Yeah, I heard that on the
Yes.
news.
Yeah.
So yeah, where they actually, you know, they go in the pool and they're swimming and they're playing and they get water in their mouth and they choke on it and then they go back to playing and then later at home they become sleepy and they actually drown in their sleep.
Mm-hmm.
So is it anything like that parents can do? Let's say you take your child.
Well, you
One-
just have to monitor them closely. I
monitor
haven't
'em.
seen too much come out on it yet. This is a fairly new thing that they're talking about now. So I haven't seen too much come out on it yet. So this acute respiratory distress syndrome, usually we're going to see this after something like either sepsis, pneumonia, smoke inhalation, or near drowning. The alveoli become more permeable. What's that mean?
Say that again?
The alveoli become more permeable.
That means it's narrow.
No. So
No, you
again,
Things-
cells
things
are
through it.
either semi-permeable or permeable. And the way cells are set up is it only allows certain things to pass through the cell. If things that are too big try to pass through, they usually can't.
Oh,
So what happens is when they become more permeable, then they allow things to pass through them that shouldn't be passing through. And that puts us at risk. All right, so the lungs are, the cells in the lungs are more permeable, and so this allows for edema to develop inside the pulmonary lungs because more fluids and stuff are passing through. All right, so over the alveolar surfaces, we're gonna have a decrease in the surfactant production because the lungs start to become stiff. So now, in combination with not having the full alveolar sacs to use that we should have because some of them are obstructed and full of liquid, we also now have less surfactant area for the lungs to work. All right, and as that happens, the lungs become stiff. We see more mucosal swelling. And so we start to develop this mucosal swelling and this cellular debris, and that causes the lung to actually collapse. That impairs the gas diffusion, okay? And so then, you know, the ARDS can continue to progress. And if it does, then the patient could go into total respiratory failure and die. So our main goal here is to improve the oxygenation and ventilation. And so we'll use mechanical ventilation with special attention to the lung volume and to the positive end expiratory pressure, or the PEEP. So in the beginning stages, we're going to see tachycardia and tachypnea. We're going to see an increased workload of breathing, nasal flaring, and retractions. And we may see or hear crackles in the lungs. There'll probably be a decrease in the pulse ox, and you're going to see some infiltrates on the X-ray because remember the cells are now more permeable, and so more stuff is seeping into the lungs. So you're going to see the thing that's seeped or infiltrated into the lungs on those chest X-rays. The child is going to need some tips on repositioning, pain management, and anxiety management. Also nutrition, okay, because they're going to have a problem with eating, and they're also going to, you also may see infections in this child. So the first thing you have to do is decrease that anxiety in the child. As far as patient care, you're opening up that airway, but then you're going to try to decrease that anxiety. And as the disease process gets worse, okay, then you're going to have to put that ventilatory support in place, and you're going to have to provide psychological support to the family because they're going to freak out when you want to intubate their child. Even if the child needs it, it's still going to freak them out. And then the pneumothorax. All right, so the pneumothorax, when you hear pneumo, think air. All right, air in the pleural space. All right, and that can be from either lung disease, cardiopulmonary resuscitation, surgery, or some kind of trauma. We'll need some sort of needle aspiration or a chest tube to get the air out. If it's really small, then it might resolve on its own. So what kind of symptoms you might see with this patient, again, is lack of air, anxiety, and possible chest pain. Tachycardia, all that would be on the affected side. And then tachypnea, retractions, nasal flaring, grunting, pallor, or cyanosis. So your job, as far as the psychosocial, is to promote the child's self-esteem through education and support. They might have multiple issues here depending on what's going on. If they have cerebral palsy, if they have cystic fibrosis, maybe they had to have a trach put in, maybe they have Laryngo Malatia, and so they may have surgical scars, they may have oxygen, they may have tubes, in and out of them. All those things are going to affect their self-esteem. And then school age, you're teaching them to help control and manage their own disease process. And you're doing this by using the little things that we talked about. Like, if you want to teach them how to do deep breathing, teach them how to blow bubbles, or teach them how to blow out the candles. What other things, what other types of play can you incorporate for this child to help them get better and manage their illness at the same time? Without it being, a drum and a bum. If they can play and engage that with that play, sometimes they can cope with it a lot better than even the parents can. Promoting family coping, okay? The family has to cope too, because no parent wants to see all these tubes coming out of their child. They don't want to see their child sick. They don't want to hear their child breathing funny, all right? And they don't want to see the physiological changes that sometimes occur, like if their if their kid were tripoding and leaning forward and drool's coming out of their mouth, how scary is that for the parent? And then culturally sensitive education and interventions. Okay, because you're going to have to be sometimes touching on these children and doing poking and prodding on them. And how are the parents going to feel about that? You already know that certain ethnic groups, like Hispanic groups, don't really want you touching all over their kid. So, how are you going to manage some of these other issues with the patient? So tell me, where does the gas exchange take place?
Alveoli.
All right, alveoli.
Alveoli.
A child with a difficult breathing and a barking cough is displaying signs associated with what condition?
Croup.
Croup. Good. The nurse is assessing the lung sounds of a child with asthma. What is the sound most likely to hear?
Musical. Wheezing.
Wheezing, that adventitious breath sound. Wheezing, that sounds like a musical note. Which condition can rapidly obstruct the airway, requiring immediate attention?
Epiglottis.
Epiglottis, good. Which sign or symptom suggests cystic fibrosis? I'll give you some. Fat in the stool or steatorrhea, decreased appetite, decreased respiratory rate, early passage of meconium in the neonatal period. A, steatorrhea, good.
Yeah.
Cystic fibrosis causes thick secretions that block the pancreatic ducts and prevent essential pancreatic enzymes from reaching the duodenum. This condition causes stools that are greasy, foul smelling, and frothy from those undigested fats. All right, one more thing I want to go over real quick, and that's TB, and then we're going to move on to cardiac. All right, so TB is a chronic disease. Right now, my last survey on this is it's not really rising all that rapidly. There is a slight increase in it because of the homeless population. There's an increase in that. And so when you bring all these people together in crowded conditions, it can put people at a higher risk. It's considered latent though, until the patient becomes symptomatic. All right, and then the cause of it is Mycobacterium tuberculosis. They do that acid-fast bacilli test to test for this acid-fast bacilli of tuberculosis. Okay, so the lung is the portal of infection, and it comes into the lungs when someone else inhales it, and then you breathe it in, those droplets. It's going to cause tissue destruction as it spreads through the lung. And that is what leads to things like pneumonia and those damaged blood vessels. Contact with an infected person would be your most concern. Okay, if a child came in contact with somebody that was infected, then you would definitely want to pay close attention. They might be asymptomatic, but if symptoms did occur, it would be things like chronic cough, anorexia, weight loss, or failure to gain weight, and fever. The TB test used to determine if the child is exposed is the MAN2, which uses that PPD. I think your book says 10 mm or greater in 48 to 72 hours indicates exposure. And once somebody has a positive PPD, we don't usually do PPDs on them anymore. We'll go to a chest x-ray.
Okay.
All right. For really young children that are HIV positive, they can be more affected by the disease. So they would treat for the TB and provide support. They would use 2 or more drugs simultaneously. Now, I believe the isoniazid and pyrazinamide are still the drugs that they give for 6 to 9 months. They might use rifampin if the child isn't responding to the isoniazid. And then they look at chest x-ray findings. They remove the source of infection if they do have an infection. Okay, so they might remove some of the TB granulomas if they're having a problem. So just a lot of encouragement here and a lot of support from the family, okay? Anybody have any questions on anything respiratory that I didn't cover or anything else in there that I may not have covered that you wanted me to cover? Okay, then we're going to cardiac.
Covered everything.
Hopefully I covered it good enough you understand it.
You did.
Okay, let's just talk a little bit about the anatomy and physiology. Okay, so you know about the heart being a muscle, you know that it's in the pericardium. You should know that there's 4 chambers. The atrium, that's the upstairs, right? That's going to be that pump during diastole. Okay, and the right and left are separated by that septum. The left ventricle shoots the blood through the aorta to the body, and the right ventricle shoots the blood from the pulmonary artery to the lungs. At birth, the ventricles are usually about the same size because there's a low amount of resistance during placental circulation. But as the left ventricle begins to function against that systemic resistance that increases after birth, it starts to become thicker than the right ventricle. So we have 4 valves: the tricuspid, the mitral, the aortic, and the pulmonic. The valves prevent backflow from the ventricles to the atria. I think about the tricuspid on the right side because 3 valves, and the bicuspid or the mitral on the left side because there's only 2. I do the same thing with the lungs, remember. That's just a way of helping me remember. And then you have these leaves on the valves, okay? And those leaves are supposed to also help prevent backflow and help with the flow of the blood from the heart. But sometimes these leaves can become stiff, or they can have problems with these little muscles that hold them in place called the chordae tendineae. And when that happens, then we can have issues with backflow, okay, into the aorta or the pulmonary artery or the ventricles. Let's talk a little bit about circulation. So blood goes back to the heart through the veins. They carry that deoxygenated blood, and it enters the right atrium from the inferior vena cava, goes into the right ventricle, to the pulmonary artery, to the lungs, where it gets that oxygen and it removes that carbon dioxide. Then the pulmonary veins are going to bring that oxygenated blood back from the lungs to that left atrium, into the left ventricle, into the aorta, and out to the rest of the body. So at birth, okay, during fetal circulation, the blood is oxygenated and waste products are removed by the placenta. Blood is shunted from those organs that aren't yet fully functional, like the lungs and the liver. So, you know, that's done by the ductus venous and the ductus arteriosus, right?
Yes.
So in the fetus, the lungs are filled with fluid before birth, okay? So the lung exchange or the gas exchange doesn't happen there because that blood only passes through the lungs enough to perfuse the tissue. But once that placenta goes, now the baby's going to rely on those lungs for oxygenation. And this is going to happen within the first few breaths. So the things that maintain fetal circulation are the umbilical vein, the arteries, the foramen ovale, the ductus arteriosus, and the ductus venous. So the umbilical vein carries the oxygenated blood from the placenta to the fetus. The umbilical arteries carry the deoxygenated blood from the fetus to the placenta. The foramen ovale serves as the septal opening between the atria of the heart, between the atria of the fetal heart. The ductus arteriosus connects to the pulmonary artery, allowing blood to bypass the lungs. And the ductus venous carries oxygenated blood from the umbilical vein to the inferior vena cava to bypass the liver. At birth, okay, we have these changes, and once the baby starts to take in the breath, the fluid in the lungs is absorbed. So a lot of that fluid is squeezed out during what process?
And when they come out from the mother's womb.
Right, when they come out of the vaginal canal, all right, the squeezing that occurs through there, a lot of that is squeezing that fluid out. And then whatever is left is going to be absorbed and placed with air. All right, so that new oxygen that's breathed in by the baby is going to dilate the pulmonary vessels, decrease the pulmonary vascular resistance, and increase that pulmonary blood flow. So now more blood flow is going to happen at the lungs. Pressure in the right atrium, the right ventricle, and the pulmonary artery are going to decrease. We'll see a gradual increase in systemic vascular resistance when the umbilical cord is clamped and the low resistance placental circulation is removed. At that point, the left arterial pressure will increase more than the right arterial pressure. the foramen ovale will be forced shut because of that unequal pressure. The ductus arteriosus will start to close, and we'll see an increase in pulmonary blood flow and a reduction in pulmonary vascular resistance. Now the foramen ovale is out of a job, okay? Because we just shut it down. It's not supposed to be working anymore. The ductus arteriosus will also be out of a job in about 4 days. Closure will happen, okay? If it doesn't close, then what's going to happen?
And
The blood is
They
going to
won't
get
be-
shunted away from the lungs, okay? And that's going to be an issue for the baby. Okay, so when the foramen ovale or the ductus arteriosus fails to close, we're going to see persistent shunting of the blood away from the lungs. All right, so we see that fetal heart rate at about
110 to 106.
day 17, okay, post-conceptual. The heart chambers and the arteries are formed during gestational weeks 2 through 8. This oxygenation of the fetus occurs through the placenta. The lungs are perfused, but are not performing that oxygenation and ventilation. We have the foramen ovale, that's that opening between the atria, and that's allowing the blood to flow from the right to the left atrium. That ductus arteriosus is allowing the blood flow between the pulmonary artery and the aorta, shunting the blood away from pulmonary circulation.
Miss Sue,
Yes.
you're not sharing your screen.
Yes, I think.
She's just.
Yeah, you are sharing, I see.
How about now?
Yes.
Yes, I see it now.
Cardiovascular
Thank you.
changes?
Thank you, yeah.
Okay. So the heart rate, it's going to be faster in infancy and it decreases as we go up in age. Blood pressure, lower in infancy and increasing as we go up in age. Heart rate and blood pressure will reach those adult levels by adolescence. Just give me 1 second. Let me pull this book back up because it keeps shutting down on me. Let me get to cardiac. So under 7, okay, the heart is going to be more horizontal and the apex will be a little bit higher in the chest. So it's going to be more right around that 4th intercostal space as opposed to the 5th with adults. Between 1 and 6, the heart is 4 times the birth size. And then as we get between 6 and 12, it will be 10 times the size it was at birth. It's still proportionately smaller at this time than any other stage in life. And then during the school age years, it starts to grow vertically inside the thoracic cavity. During adolescence, it continues to just keep on growing. Okay, at birth, our ventricle walls are similar in thickness. We talked about this, but the left one is going to become thicker as it starts to work. The myocytes, which are the myocardial cells in the heart, they're going to be thinner and not as compliant as those of adults. The right ventricular function will be dominant until the left one starts to really work, and then eventually it will become more dominant over time. At rest, the infant's heart will show greater resting tension than the adults. So it may have more of a stretch which could actually lead to cardiac output. So what do I mean by a stretch? Anybody know?
Can you please repeat it? Sorry.
So as fluid comes into the heart, it causes it to stretch, okay? And as it stretches, it can release certain things to maintain homeostasis. Like if you were in heart failure, and I believe I've talked about this before, especially in Med-Surg 1, you should have talked about this. In heart failure, what happens is the ventricles become fluid overloaded, right? So as they become fluid overload, they stretch. And as they stretch, it causes them to release something called B natriuretic peptide.
Oh, yes. Yes.
And that B natriuretic peptide is a chemical messenger. So it's going to go run and tell the brain, hey, something's wrong here. Okay, we got too much fluid here. The heart is supposed to be pumping fluid out, but it's not. Help me out here, bro. That's the idea of those chemicals. We also release atrial natriuretic peptides. How do those help?
That's if we have a overload on atrium. So
sort of. So
that's
they're
kind of send a
the
signal
renin,
to
aldosterone, angiotensin system, and so those natriuretic peptides are helping us control blood pressure. So yeah, when the atriums become too full, it'll stretch and it can release these peptides to help control the blood pressure. So they're all chemical messengers that run and tell the brain, hey bro, something's happening down here. You need to come and check it out. You're not doing your job. Okay. What else? Okay, so we talked about the normal infant rate being from 90 to 60, okay? And then in toddler, it's gonna go down to about 80 to 115. And then school age and adolescent, we start getting into those normal ranges of 60 to 100. Things you might find are murmurs that are usually innocent, and these can cause heart sounds to sound a little different. A lot of times children will outgrow these. Okay, and then the blood pressure. So the average in the infant is going to be about 80 over 55, and then it'll start to rise. To a preschooler will be around 90 or 110 over 55. And then school age, we start to see more normalized, like 120 over 60. As they become an adolescent, now they're meeting those adult blood pressures of like 100 over 70 or 120 over 80. Congenital heart disease, there's going to be anomalies present. That means some sort of birth defect or some sort of structural defect. Congenital heart disease counts for the large percentage of all birth defects. Acquired heart disease, this would be something that they develop after birth. Heart failure is the most common reason for admission, and it can be caused by a wide variety of sources, okay, or be a complication of some sort of congenital heart defect. So the congenital heart defect is going to be based on its hemodynamic characteristics. Let's see. Let me just pull this up here. We're in chapter 41, right?
Yeah.
Yes.
Do you have a phone number for the student? She didn't show up today. And she didn't call me.
I did, but I can't really pull right now because I'm in the middle of a session.
Okay.
Just put the student's name there and then I'll shoot you the phone number on the text.
Very good.
All right, so most congenital heart defects are involving an increase in the pulmonary blood flow, where the left side of the heart is going to have more pressure than the right. And there's some shunting of the blood. Okay, so this can actually affect the way that the heart pumps. And the thing is, if it's putting an increased workload on the heart, it can eventually cause the heart to fail. Because remember, the heart is a muscle. All right, and as it puts additional workload on the heart, for one, it can cause the ventricles to become hypertrophied. And if this happens, what's going to happen is it's not just like the whole ventricle grows. What happens is the walls become thicker. So what happens when the walls of the heart become thicker?
It's hard ventricles to squeeze. I mean, the
Action
blood
of the heart
flow.
is decreased.
The heart.
It decreases the amount of blood that can go into that ventricle. So it's going to affect our overall circulation of that blood, and the heart is actually going to have to work harder here. And also, because of that forceful pumping, it can cause left to right shunting. It also can cause, if there's left to right shunting already going on, for it to reverse to right to left shunting. And if that occurs, then that deoxygenated blood can mix with the oxygenated blood and cause a low O2 sat all the way around for that child. So if they have too much blood flow to the lungs, it can result in tachypnea or tachycardia, and that will cause them to burn more calories. And this means that even if they're eating well, they may not be able to, they're going to use all those calories up. And so they're not going to get a lot of nutrition out of them because they have a high metabolism level. And the children might end up with something called pulmonary hypertension. All right, so for children with congenital defects with increased pulmonary blood flow, oxygen supplementation won't help them because it vasodilates. And that causes the pulmonary blood flow to be even greater. So it eventually will cause more of a problem with the oxygenation. Examples of defects with increased pulmonary blood flow are atrial septal defects and ventral septal defects, atrioventricular canal defects, and PDA defects. Disorders with decreased pulmonary blood flow are Tetralogy of Flow and tricuspid atresia. Obstructed orders would be coarction of the aorta, aortic stenosis, pulmonary stenosis. And then mixed disorders would be transposition of the great vessels, the total anomalous pulmonary venous return, the truncus arteriosus, and the hypoplastic left heart syndrome. So we use EKG, okay? I don't know if I have these slides up in order. Let me see if I can pull these things up on here first, the tetralogy of flow and all that, and then I'll go back to these diagnostic tests just so I can kind of stay in line with the slides. All right, let's look at you guys should be kind of familiar with tetralogy of flow, right? They like to ask a lot of questions about that.
Yeah, it was a lot of questions about that when I prep you a lot, so.
Okay. So what's happening in this tetralogy of flow? What's happening to the baby? The baby's born with what?
Is it like a pulmonary stenosis?
That's 4 different one. It owns with.
Okay, they're born with a few different things, right?
Yeah, it's 4 of them.
Pulmonary stenosis and
And they have a right ventricular
Overriding aorta.
hypertrophy,
Um,
and they have
Right
overriding
ventricular hypertrophy.
there's a right ventricle hypertrophy and
pulmonary stenosis.
Okay, so tetralogy flow is a combination of 4 cardiac defects: ventricular septal defect, right ventricular outflow obstruction or pulmonic stenosis, right ventricular hypertrophy, and overriding aorta, or the aorta being positioned over the ventral septal defect. So the blood is shunting from right to left through that ventral septal defect, and this is allowing that unoxygenated blood to mix with that oxygenated blood. That causes the patient to have that cyanosis. Cause is unknown. It has been associated or attributed to some fetal alcohol syndrome, all right, and use of something called thalidomide during pregnancy. So we have this unoxygenated venous blood going back to the right side of the heart. It might go through the ventral septal defect to the left ventricle and bypass the lungs, or it might enter the pulmonary artery, depending on how severe the pulmonary stenosis is. The aorta will override both ventricles in this case. The ventricular septal defect usually is in the right ventricle. And so we may have severe obstruction of the right ventricular outflow, causing that right to left shunt. We see a decrease in systemic arterial oxygenation, cyanosis, reduced pulmonary blood flow, hypoplasia of the pulmonary vascular system, right ventricular hypertrophy. And then in response to that, we have now an extra force trying to push blood into that stenotic pulmonary artery. So cyanosis is the hallmark. The children will have these TET spells characterized by shortness of breath, deep sighing respirations, bradycardia, fainting, seizures, possible loss of consciousness after exercise, crying, straining, infection, or fevers. Other signs would include clubbing, diminished exercise tolerance, increased shortness of breath, especially with exertion, growth retardation, difficulty eating. You may see them squatting with shortness of breath. You might hear a loud systolic murmur along the left sternal border. And then continuous murmur of the ductus in a patient with a large PDA. Also a obvious right ventricular impulse and a thrill at the left sternal border. We would do chest x-rays and EKG. All right, the chest x-ray would show us a boot-shaped cardiac silhouette. All right, that boot shape is indicative of the TET. The EKG would show right ventricular hypertrophy, right axis deviation, and possible right atrial hypertrophy. The echocardiograph and the cardiac cath would help us look at those defects. Complications: hypersonic spells, right ventricular dysfunction, infective endocarditis, polycythemia, we talked about that, and death. So how do we manage it? We use that knee chest position, right? And then we give oxygen and morphine to decrease the workload on the heart and help improve the oxygenation. We might give something called propanolol to prevent the TET spells, and prophylactic antibiotics to prevent infective carditis. Palliative surgery, okay, to reduce the hypoxia. They use something called a Blalock Taussig procedure, and that connects the subclavian artery to the pulmonary artery. We might have to surgically close to relieve pulmonic stenosis, the ventral septal defect. And that would help direct the left ventricular outflow back towards the aortic. This is sometimes referred to as the Brock procedure. Teach the parents, okay? The child will set their own exercises based on what they can tolerate. They should know what a TET spell looks like and how to improve the cyanosis in the baby, okay, if it does happen. They should also know what to report and when to report it. Because of that right to left shunting, we would treat IV lines like arterial lines, all right? And be cautious that clots, okay, can occur, and we have to be careful. If the child requires medical attention, we would want to definitely let the people know that this child has the Tetralogy of Flow.
Miss Sue, where are you reading from? Because I'm trying to like catch everything you see in the book, and you have like so much more information than what our actual book has.
Yeah, so I have my own little notebook.
Oh, got it. Okay, because I'm like, no, there's a lot of the stuff that you're saying out loud.
I'm not trying to give it to you straight from the book. I am trying to make sure that the information matches what your book says, which I'm pretty sure that it's pretty muchly on point just from what I reviewed and looked at. But I'm trying to give it to you in a manner that's a little more broken down than what the book is giving it to you.
Yeah, I get that, but you are giving some extra stuff that I don't see in the book. I just will have to listen to this a couple times. Even in the respiratory section, I was trying to follow with the book, and a lot of things that you were saying, I was like, yeah, I don't see that in the book. So I'll just listen to this with the reading, because you are giving out like a couple more things that's not here.
So I would, I'm recording this and I'm going to put it up on YouTube for you guys so that you can go back and listen to it again, because I know I'm going through it pretty fast. And we actually only have about 8 more minutes. So what I'm going to do is I'll finish it out until 11, what I can. And then I'm going to try to go back in. I won't be able to do it tonight because I got a birthday party. But if I get up early enough in the morning, I might be able to get it in before the rest of my day starts to just finish out the recording on this PowerPoint so that at least I can post it up and give you guys that.
And you said on YouTube?
Yeah.
All right, good. Okay.
I'll send you the link once it's up there.
Okay.
All right, so let's talk a little bit about some of these other ones, the atrial septal defect. I lost my page somewhere in the middle of that. Okay. This is a hole in the actual septum wall that divides the right atrium from the left. There's 3 different kinds. I'm not going to go into each different one. All right, but when it's small, most infants can still have that spontaneous closure. If it doesn't close by the age of 3, then they will have to close it with surgery. The blood in the ASD, the blood is flowing from the left atrium to the right atrium. And that's because of the differences in pressure. Remember that, you know, that's why we talk about the different things like diffusion, osmosis, and all that, because when pressure is different in one area than the other, it can cause certain things to occur. So in this case, that pressure change is causing the shunting of the blood that's entering the right atrium. So that leads to an increase of blood flow into the lungs. And if it continues to go untreated, then your child can develop pulmonary hypertension, heart failure, and atrial arrhythmias. So most of these kids are going to be asymptomatic. You would want to get a health history on them, EKGs, to look at, you know, any arrhythmias to make sure that there's normal activity in the heart and that there's nothing going on with the electrocardiogram. Again, if they do have an increase in the size of the heart, you should be able to see that on radiography. The ventral septal defect. This is a large opening between the right and left ventricular chambers. It's a common congenital heart defect. It actually encompasses about 25% of all of them. Usually will close on its own by 2 years old if it's small. If it doesn't close by 2, then they might repair the defect so that the child doesn't develop the pulmonary disease. Again, openings can vary in the size, so depending on how severe it is, on how they're going to fix it. If they have a small one, they might not even have symptoms. But in this case, the blood is shunting, okay? Pulmonary vascular resistance and the systemic vascular resistance will determine the direction of the blood flow. We may see a left to right shunt if the pulmonary vascular resistance is low. Heart failure is a common issue for these children, okay? If it goes unrepaired, even if it's only moderate, if they have this ventral septal defect and it stays for a long time, they can develop heart failure as well as aortic valve regurgitation and the ineffective endocarditis. So again, a good health history on these patients. Lab and diagnostic tests would be an MRI with a Doppler. The Doppler would look at the shunting, and then also they'd be looking for things like right ventricular hypertrophy and dilation of the pulmonary artery from that increase in blood flow. They also might use a cardiac catheterization to determine how much blood is actually going into that pulmonary circulation. All right, let me just go over real quick this mixed disorders, the transposition of the great vessels, and then the rest I will put in the video for you guys. So in transposition of the great arteries, the aorta rises from the right ventricle and the pulmonary artery rises from the left ventricle. It produces two non-communicating circulatory systems. So the cause of this is unknown, but this transposed pulmonary artery carries the oxygenated blood back to the lungs instead of to the left side of the heart. The transposed aorta takes the unoxygenated blood and puts it in systemic circulation instead of going to the lungs. So the communication system is broken down between the pulmonary and the systemic circulation that we need for survival. You might see other congenital defects like PDA, ASD, and VSD. The defects cause holes in the heart that allow the blood to go from one side to the other so that the oxygenated and deoxygenated blood mix and then flow out to the rest of the body. So these patients, what would you see? Transposition of the great arteries, cyanosis from birth, and tachypnea that gets worse when they cry. A possible gallop rhythm, tachycardia, dyspnea, cardiomegaly, hepatomegaly, murmurs of ASD, VSD, or PDA, and a loud S2 sound. You'll have diminished exercise tolerance, fatigue, and clubbing. Chest x-rays would show the increased pulmonary vascular markings, the right atrial and ventricular enlargement, and it would make the heart look like an oblong appearance. You might also see a right axis deviation and right ventricular hypertrophy on the EKG. The echocardiograph is going to show the reverse position of the aorta and the pulmonary artery, and it might show some other cardiac defects. Cardiac cath will show a decrease in the O2 sats in the left ventricular blood and the aortic blood, and an increase in both right atrial ventricular and pulmonary artery saturation and ventricular systolic equal to systemic pressure. All right, so complications, infective endocarditis and death. So we treat this with prostaglandin E to maintain patency of the ductus arteriosus, prophylactic antibiotics to prevent infective carditis. We might have to put a balloon during the cardiac cath to enlarge the foramen ovale, and that could help improve oxygenation by allowing a greater mixing of the pulmonary and systemic circulation. Corrective surgery to redirect blood flow, and that's usually done within the first few weeks of life. So we're monitoring vital signs, pulse ox, ionos, and kidney function, assessing cardiovascular and respiratory function for signs of decrease, monitoring fluid status for fluid volume overload by weighing the child daily, offering high calorie foods that are easy for the child to digest, and encouraging the parents to help the child assume new activity levels and independence. All right, so I will go back over the rest of these. I stopped at slide 6, and then I will pop everything up on YouTube as soon as I can, and I'll try to send you guys out a message to let you know that it's done. As far as the other slides that I was trying to give you from Mr. Corsi, some of them may have came through. A lot of them, Google won't let me share anymore. I don't know what's up with that, but it says I maxed out my sharing capacity. So I was trying to put them on a zip drive. I'm still trying to put them on a zip drive so I can email them out like that. I don't know how many of you have been able to open a zip drive, but it'll come with a password or whatever if I do send it that way. And then for the rest of the term, my suggestion is to bring me a flash drive so I could just download what I do have. All right.
Thank you, Mr.
Okay, thank you so
Thank
much.
you.
Anybody have questions?
Ms. Sue, so if we have a flash drive, we can bring it in Monday?
Yep.
Done?
Bring it in, but don't forget what time your exam is so we don't get messed up.
Can we,
Okay.
so can I
How
ask
about
a question?
after the, will you be around after the exam?
I will.
Okay.
I'm sorry, I was unclear about, are we to remain in class after midterm, or are we going home? Because no, I'm not clear about that.
So for midterms, I think you guys have 2 classes that are going to be on Zoom this week.
No, yeah, I'm
Right.
aware of that. I'm talking about the actual day, like Monday, like
After the exam, do we stay in school or we go home?
You won't have regular class the week of midterms. The only
Got it. That's-
classes you have are those 2 makeups for peds, and one is for Memorial Day weekend, and the other one is for the 4th of July.
Okay, all right, got it. All right, thank you.
Okay.
Thank you.
Thank
You're welcome.
you.
Have a good Saturday.
Thank you.
Thank you.
Oh, Lord.